be talking about bupivacaine injection versus mini tenotomy for small angle horizontal strabismus in children. That's on behalf of my dear colleagues and my dear professor, Dr. Helen Hillary. Correction of small angle deviations less than 15% diopters can be challenging. A normal recess resect procedure can lead to drawbacks such as conjunctival scarring, changing the arc of contact to the sclera, overcorrection, or limitation of ocular motility. Alternatively, minimally invasive surgical approaches such as bupivacaine injection or mini tenotomy can be used as we did in our research. Bupivacaine is an amino-acid local anesthetic. Its adequate injection can result in strabismus and diplopia. And bupivacaine, once injected into the extraocular muscles, elicits an immediate myotoxic response. However, it spares the satellite cells and the myofibroblasts. This allows for immediate regeneration of the muscle fibers and myocytes. The resulting myocytes are of greater contractile strength and size. Mini tenotomy is a minimally invasive weakening procedure that involves cutting the center of the tendon at the insertion. It can be used to treat diplopia and small angle deviations, vertical deviations up to 6% diopters, horizontal deviations of up to 16% diopters. In our study, we compared bupivacaine injection to mini tenotomy for horizontal small angle strabismus. We included patients 2 to 14 years of age with angles less than 15% diopters. We included patients who had postoperative residual or consecutive strabismus, again less than 15% diopters, providing that the muscle was not previously operated. We excluded patients not willing to undergo the procedure, angles more than 15, previously operated muscles, significant A or V pattern, the presence of paresis or mechanical restriction, and any systemic disease affecting the muscle pathology. We had 40 children, and they were divided into 2 groups. The first group underwent bilateral 0.75% bupivacaine injection, and the second group underwent bilateral central mini tenotomy. All procedures were performed under general anesthesia. The first group, which received 3 milliliters of 0.75% bupivacaine, we injected both medial recti in cases of exotropes and both lateral recti in cases of isotrope. This was done through a small fornix incision after muscle localization without dissection. You inject in the posterior and middle third of the muscle. We performed MRI before the surgery at 30 to 60 days post-injection. The second group underwent mini tenotomy after grasping 3 to 4 millimeters of the central tendon, after localization of the lateral rectus 8 to 9 millimeters from the limbus, or the medial rectus 7 to 8 millimeters. We were able to cut 3 to 4 millimeters of the central tendon using blunt Westcott scissors, and the conjunctiva was left unsutured. Our criteria of success was a postoperative alignment within 5% diopters, with and without correction, in the primary position for distance and near, and maintained at 6-month follow-up. The baseline characteristics of both groups were very similar. Approximately 50% were male to female ratio. We had amblyopic patient, 25% in bupivacaine group and 35% in the mini tenotomy group. Previous surgery was not a contraindication, so we did have patients who had performed previous strabismus surgery, cataract surgeries, or glaucoma. The mean angle of deviation for near and far for both groups was the same, about 14 to 15% diopters. Regarding the angle at 6-month follow-up period, we can see that both distance and near for both Group A and Group B were able to be corrected up to 10% diopters at 6 months. The stability of results, because we had a very strict criteria of success of improvement less than 5% diopters, we found that the bupivacaine and the mini tenotomy techniques at 6 months, the percentage was not very large. 16% for exotropes for both bupivacaine and mini tenotomy, no patient of esotropia using bupivacaine, and 25% with mini tenotomy. However, when we slackened a little bit of our criteria, where the improvement was with 5 to 10 prism diopters, the numbers increased markedly so that we had 50% in exotropic patients using bupivacaine or mini tenotomy, and 60% of esotropic patients with bupivacaine, and 37% of patients with mini tenotomy. The comparison between both groups, we found that both bupivacaine and mini tenotomy can correct alignment of approximately 5 prism diopters. We also compared from the first week to 6 months between bupivacaine and mini tenotomy, and we found that bupivacaine had a worsening of alignment in the first week, but this was owed to the myotoxic response. But the regeneration allowed the marked improvement so that both cases, both groups had comparable results at the end of 6 months. These are cases, this is examples of bupivacaine cases. This is a patient with partially accommodative esotropia with a near angle with glasses of 14 prism diopters, and post-injection, the patient was able to lose the bifocal and had a near angle of 4 prism diopters. This is another case with intermittent XT with a pre-injection angle of 15 prism diopters, and post-injection, the patient was down to 6 prism diopters. For mini tenotomy, this is another patient with a partially accommodative esotropia with a preoperative angle with glasses of 14, and that was able to be corrected to 5 prism diopters with glasses. Another intermittent XT case who did a mini tenotomy with a preoperative angle of 16 prism diopters and a postoperative angle of 8 prism diopters. Performing MRI for the medial rectus, we injected a total of 24 muscles. 18 of these muscles showed a volume and thickness increase of 6%, while 6 muscles showed under 1% increase in both volume and thickness. And MRI of the lateral rectus, we injected a total of 16 muscles. 12 of them showed again 6% increase in volume and thickness, and 4 muscles showed none to less than 1%. So the comparison of the difference in both exotropic and esotropic cases comparing volume and thickness, we found that in exotropic patient there was a volume increase of 23 millimeter cubed, and in esotropic patients 17, and a thickness of 0.12 and 0.13 in exotropic and esotropic patients respectively. I just want to note that these Yes, I just want to note that these cases, although the volume and thickness in volume was small, but some and a lot of patients showed marked improvement in alignment. This is an MRI of an esotropic patient where the lateral rectus was injected, and the increase of thickness was 0.17 millimeters with improvement of alignment. This is an MRI of an exotropic patient, and the medial rectus showed an increase in thickness of 0.33 millimeters, again with improvement of alignment. This is a patient where the MRI was injected in an exotropic patient, and therefore there was a minimal increase in thickness of 0.04 millimeters, but this patient also showed improvement in alignment. This is an MRI of a lateral rectile and esotropic patient, and although the thickness increased of 0.12 millimeters, but this patient did not show improvement in alignment. So bupivacaine and mini tenotomy show comparable success rates in the treatment of small angle strabismus in children. They are both rapid and less invasive techniques, and they can correct approximately 5 to 10 prism diopters, and it leaves us the opportunity to perform standard surgery later on. The limitations to our study was that a larger sample size needs to be studied, different doses of bupivacaine needs to be explored in order to establish which is the most beneficial. We're unable to resnip to improve results because children need general anesthesia, and we did not study the effect on other types of strabismus. Thank you very much.